academic institution. He is still running the Brain Research Institute. And he completely dedicated. I think if you utilize his services, and I will tell the director to kindly see, probably you will be able to succeed in some of these achievements which are there. You will also know that I rather felt very ashamed when you mentioned Padma Shri Awadi. You don't know that Professor Tandon is the one who is Padma Bhushan. And see, he is the man who, just like Painters, there are very few genuine, I should say, there are many pseudo people who have got all these awards. I am one of them. There are many pseudo peoples, but there are very few genuine, out of which I and Professor Painter and Professor P. Anton is one. And I find you never mention about him, that he is the person who is the holder of this, and the government of India recognizes contributions. Well, I will only say, as far as Dr. God is concerned, you have a director. I will only, my advice there, we look toward this Patel Chest Institute as one of the big institute in chest diseases, a leading institute who have to guide the research, the academic activities in the chest diseases. And I think when you get anybody who is the director, it becomes the onus of the faculty to help the person to see that the institute become one. To make an institute, you know, the whole faculty has to work together. No one person can make an institute. So I really see that if the faculty help the person, and then you find the institute can really go up, and you can have the situation which are your all promises which can be fulfilled. There was some problem sometime which I heard in the institute. There was some syringes were thrown out here and there at the back. And I personally feel all these things should be dealt together with the faculty. And that is the most important. The institute can be destroyed by one person, but for making the institute, you have to work together to do that. Now, coming to Professor Sabda, I think he is sitting here. His work is known to you all. He has done a tremendous work in the pollution. And we all read that, and his work now on the allergy also. And we wish him a good success, that he will continue to do that. Finally, I will say Professor Bhana already has said, actually I also read about it, that he graduated from the medical college in Cairo. And I also thought the same, that we are so good linked with him. And later on, I have gone through a lot of work which Professor Bhana has done on the IgE, and I found here he has given a lecture also on the IgE, the total amount of IgE in the allergy, and he has also worked on the various other aspects, but not only the lung allergy, he has plenty of work done in the dermatological allergy also. And the work done, which is particularly in the Stevens-Johnson syndrome and dermonecrolysis, and the use of IV immunoglobulins, which is also only 2 or 3 papers in the whole world literature. So the plenty of work has been done, and one was very happy to know that you are the one who are going to give Prof. Vishwanathan Oration today. Thank you very much. I have nothing more to say. I only wish you all good luck. And there are a number of participants who have participated in this workshop, and I wish them that they go back after having learned a good amount about allergy. I only say the problem is when you do the allergy test, kindly see that you do in a proper person, with a proper situation. And the notion among the public is there, you just catch hold of man and then you do all the tests, and then you tell him you are now sensitive to 10 antigens, and then say what to do. I think it is a need, a good selection of a person, and only then you can really be a successful person. And anti-allergy tests which are being done, you have to be very, very careful, and I am quite sure you must have learned from this workshop how to choose which particular person to choose, where you will really find that these anti-allergic tests will be beneficial, or desensitization will be beneficial. Thank you very much.
I now invite Professor Sami Bhana to deliver his lecture for the Professor Raman Vishwanathan Vallabhbhai Patel Chest Institute Oration, titled Be the Doctor First and Last.
I am overwhelmed, genuinely. Those of you who heard me over the past 2 days, they saw my normal tone of voice, how I spoke, as if I am somebody. But now, among the distinguished senior teachers, professors at the podium, I felt I am very little, I am so minute for this session. Professor Gularia, Professor Tandon, Professor Chapra, Professor Gaur, you were so kind to me. You mentioned words that almost make me speechless. I truly mean that. I was very, very honored and impressed when I was informed about this honor, particularly after I read something online about Professor Raman Vishwanathan. And I said to myself, what did I do to deserve that? And remembered a story about an art fair or a contest of artists. And they announced the first winner for his best painting in the fair. And when he was called at the podium to receive the award, he was told that your painting was the best. And he said, but I didn't present my best painting. And they told him, why not? He said, because I didn't make it yet. And I feel in that, I didn't make it yet to deserve, so I feel greatly indebted to an award like that. Regarding the title that have been commented on multiple times, of course it was highly selected for this occasion. I never gave that title for anything before. But when I read about Professor Raman Vishwanathan, how much he accomplished at an era with very little lab, very little technology. And as Professor Tandon referred to, the lab and the machines are taking over. And I am not yielding to that. I live now for almost 40 years in the United States. I have been always in universities, big universities. I have facilities. We don't worry about cost, whether the patient is paying or the insurance or nobody. We are at the university, teaching university. And teaching universities are known to use a lot of investigations. But I'm not yielding to that. And I will continue in the remaining few years in my career or my life to resist that the lab and the machines take over. So when I read about Professor Vishwanathan, I said, well, what I'm going to give a talk about? Asthma and allergy immunology. I'm going to talk about the value of a physician that's being degraded. So you heard about the great professor. I just put a couple of slides for you to look at quickly how much he achieved from the time receiving his MBBS and a doctorate degree in medicine, to be a head of a department, professor, served on the Army, deputy director of the General Health Services, head of the Department of Medicine, dean of the Faculty of Medical School in Delhi, founder, director of the VP Chest Institute, and continued as honorary professor in the Chest Institute until his death, founder and president of the Indian Association, editor-in-chief of the Indian Journal of Chest Diseases, president of the Indian College of Allergy and Applied Immunology, several books, numerous research studies relevant to tuberculosis and other pulmonary diseases. So he truly earned the title father of chest medicine in India. And I commend you that you are keeping memories of a person like that alive. I am in a country, which is the United States, that we look at the new. It's very hurting to me with my background that I see once the person retired as if he or she didn't exist anymore. Not realizing that I'm standing because of the predecessors. It is hurting me. But I share with you the great respect and the honor that you are giving to our predecessors. He's achieved as being a doctor much earlier than the advanced and modern technologies I mentioned. So now I'm going to choose, although I'm at the university setting, how I practice some of this in the environment. So I'm going to show you some rare cases, some frustrating cases, and how much the lab helped me in that, how much that I need in that. So let's start with a simple thing here. Follow with me as if this is your patient. Simple, this is simple case, not very sophisticated at all. This is a breastfed baby, exclusively for 5 months, very commendable, and start to add foods and continued breastfeeding for 18 months, which is very good, and I assume many mothers in India are doing this. But there is a strong genetic predisposition for allergy. At 5 months, very young age, got anaphylaxis to a few milliliters of cow's milk formula. Very frightening, life-threatening. At 6 months, got urticaria to egg, soy, and peanut. Early in life got all these troubles. I started to see him at the age of 17 months. His total IgE was very high. That's the thermometer of allergy. Almost 10 times what's expected. And specific IgE was very strongly positive to cow's milk, and that supports the history, that's real. And to the egg also supportive of the history, and soy and peanut, so compatible. The lab, how much did the lab add to a good history here? We got a good history, we confirmed what is that. I'm not minimizing the lab, but I just say how we use it judicially. Reassured the family that milk allergy and egg allergy has much better prognosis than fish and seafood and peanut allergy. So I expect outgrowing of these allergies, strictly avoid these so that the immune system will forget them. At the age of 4 years, he got urticaria and upper respiratory symptoms while in a bathtub. What is the diagnosis here? Acute urticaria and upper respiratory symptoms. Multiple system, that's anaphylaxis. What could be the cause here? A baby taking a bath in a tub and got anaphylaxis. We know what he's allergic to, but he's taking a bath. We put a differential diagnosis. There's possibility there is heat-induced urticaria. That's one of the physical urticarias. It's possible that the soap or shampoo did that. Is it possible you have dermographism, another type of physical urticaria, while the mother was giving a bath, rubbing the skin, and they released a lot of histamine and other mediators? Yes. Is it possible he has cutaneous mastocytosis, but the skin was clear? Because if there is cutaneous mastocytosis and there is rubbing, there's a lot of release of histamine that can give anaphylaxis. Did the baby eat any food with hidden milk or egg or something he's allergic to, but he was taking a bath, was not eating? Then what is it? What other lab work to do to help us in this? more history. The doctor again. So, more history said, while he was in the bathtub, his younger brother spilled a little milk from his plastic cup, which has an opening there, place there. So little milk from that cup went into water. So a highly allergic baby caused that reaction. Look at the quantity of allergen that can cause a systemic anaphylaxis in a baby. And the lab could not do that for us. You as a clinician, take a history, put the words together, puzzle together. And this young lady had frequent acute episodes of generalized urticaria. Some pleasant for a teenager, beautiful girl getting the urticaria every now and then. Even any of us gets urticaria, the itch. It's not a very dangerous thing, but it's very annoying. Disfiguring and itching and irritable. Some episodes occurred after eating, particularly ice cream. All right, it has good history. But no relationship to specific environmental exposures, particular places, days of work, time of day, menstruation, or stress. In urticaria work as detectives. In allergy in general we do, but in urticaria in particular, work like good police detectives, where it happened, when, at what time, and all that, to suspect the criminals. She's not on any medications or contraceptives or vitamins. So what test should be done? Yeah. The history is coming after eating. So we have to suspect foods. Skin prick testing to a large number of foods, all negative. The episodes recurred, responded well to antihistamines. And while I am just puzzled by this, particularly when patients are referred with high expectation, that puts a tremendous burden in you. When the patient coming at you with high expectations, your margin of failure is very thin, but afforded. So I was reading, and I gained something outside textbooks, that acetylsalicylic acid is frequently used as acidifier in commercially prepared food, including ice cream. How do you think that's a drug related here? Well, I got the girl in the office while she does not have any rash at all, and I started with small quantities of aspirin channels, and I induced generalized urticaria in her and the angioedema to 100 milligram only of aspirin. Avoidance of the aspirin and non-steroidals relieved the whole things, told her to read the labels. Unfortunately, not all labels are complete to write these things. But this is her image that I did to her in the clinic, but to solve the problem. 100 milligram caused generalized urticaria all over and angioedema. Child with recurrent rash, the 1-year-old boy referred for immunology evaluation. He was referred by another allergist. He didn't have much time to go into immunologic evaluation as we do at the university. That child had pruritic rash for 4 months, eosinophilia 9%, very high, 1200, and highly elevated total IgE level. Look at that, at 1 year of age, 10 units is the normal. This is thousands here. Multiple times done, ranging from up to almost 9,000. No relationship to food or environmental exposure. No history of significant infections that we suspect in children as the product of infection or the breakdown of the tissue may be the cause of urticaria. Family history was unremarkable. Just look and find a clue. Go away. Physical examination appeared normal. Lymph nodes and tonsils are normal, which is reassuring. He does not have congenital hypogammaglobulinemia, and the lymph nodes are great. have mild rhinoconjunctivitis, not a big deal. It has the rash, pleomorphic, erythematous, papular, urticaria rash on the face, arms, and less on the trunk, with some excoriation and scarring, which made the original allergist suspect there may be immune deficiency in that patient. And this is the picture of that child. You will see what's on his face, in his hands, in his thigh, leg, over these kinds. Sometimes are super infected, but usually are not. So there is fear. Family with a young infant having this problem went to another specialist. So I have to do all what I can. I have the labs, I have the knowledge. So CBC normal, except for eosinophilia that was found before. Immunoglobulins and subclasses and complement assay normal. Total IgE still continue to be very high. Specific IgE was 4+ strong to melt and to egg white, and that's it. The others were negative. But there was no history that's related to food. So we have to be careful. The lab serves me. I don't serve the lab. So if I don't agree with the lab, that's all right, I disregard. Because the child preparation was not related to foods, particularly it is an obvious food by the test here is milk and egg. It will know. We evaluated the immune system further. Antibodies to diphtheria and tetanus were fine. Look for parasites because if the total IgE and eosinophilia is towards negative, serum antibodies to various parasites, although he's an American, is still negative. Skin lesion biopsy showed mixed inflammatory cells with eosinophils, non-specific, didn't tell me the diagnosis.